everyone. Welcome to the Premi Chats, and thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, as known as CPBF. We are a charitable organization, and our mission is to empower families of premature babies through support and education. This Premi Chat series is one of the many initiatives we have to bring education for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us their knowledge and expertise. Also, in our website, canadianpremis.org, parents will find all kinds of resources and support. And today we are going to talk about developmental coordination disorder, as known as DCD. We will learn why children who are born very preterm are at a high risk for DCD, and how it affects a child's ability to perform daily tasks and learn motor skills. Dr. Zwicker will outline the characteristics of DCD, describe evidence-based therapy that helps children with DCD learn motor skills, and share resources to help parents, teachers, and coaches better support children. And she's joining me here live from Vancouver. Dr. Jill Zwicker is an associate professor in the Department of Occupational Science and Occupational Therapy at the University of British Columbia and an investigator at BC Children's Hospital in Vancouver. She holds a Tier 2 Canada Research Chair in Pediatric Brain Development and Rehabilitation and is one of the few occupational therapists worldwide with expertise in pediatric brain imaging. As an internationally recognized scholar for her work with children with DCD, Dr. Zwicker's research program aims to better understand potential causes of DCD, to evaluate the effect of rehabilitation on motor skill and brain development, and also to inform evidence-based care to improve outcomes for children with DCD. Dr. Zwicker is also interested in the relationship of prematurity and DCD, and is examining early brain development and motor outcomes of premature newborns. Dr. Zwicker, thank you so much for joining us here today.
Thank you so much for having me. It's a pleasure to be here.
Yeah, I'm very excited because this is something that I learned recently from you, and I'm sure many of our families will be very interested in learning more as well. So the floor is yours, and for all of you watching us live, please do send your questions, your comments, that Dr. Zwicker will address them at the end of her presentation. Thank you.
Great. Well, thank you so much, and it's an honor to be here. And what I thought I'd do is just talk for about 30 minutes or so. But I'd first like to just acknowledge that my research is conducted on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm grateful to live, work, play, and learn on their lands. So in the next 30 minutes, what I'd like to do is just give you an overview of what developmental coordination disorder is, or DCD, how to have your child assessed and diagnosed if appropriate, the treatment options for children with DCD, and then some resources to which you can refer after the presentation. So first of all, what is DCD? It's actually a neurodevelopmental disorder that's present from birth, but unfortunately it's often not recognized until the child reaches school age. And this is something that we're actively working on, is to try and identify much earlier in life children who are at risk of this disorder. And how this disorder affects children is it interferes with their ability to perform and learn motor skills. So these could be fine motor skills, such as learning to print or cut with scissors, tie shoelaces, and so on. It could be with gross motor skills, such as learning to ride a bicycle, learning how to swim, participating in sports, for instance. And more commonly, it affects both fine and gross motor skills. It's very common. It affects about 5 to 6% of school-age children, which, if we put that number in the Canadian population and the average classroom size, that's 1 to 2 children in every classroom. But I can guarantee you not all children would have a diagnosis. And that's something that we'll talk about today. I don't want to get too medical here, but I do want to just give you what the diagnostic criteria are for DCD, and then I'll discuss these a little bit further as we get along in the presentation. The first criterion is that the motor skills are substantially below what you would expect for the child's age and their opportunity for learning. So traditional daily life activities, you don't need to have any special training to have opportunities for learning. So it's just through day-to-day activities. But the child's motor skills are substantially below what you would expect. The second thing is that this motor deficit must significantly interfere with daily activities. So whether this is through self-care, being able to dress themselves, use a knife and fork, print legibly at school, participate in leisure activities like riding a bike or swimming. So the motor skill deficit interferes with their performance in these activities. The third criterion is that the symptoms appear early in life. So these are something that you would know or recognize from when the child is very young. Not necessarily in terms of developmental milestones, but more so in learning motor skills. It seems to take much longer for children with DCD. And finally, that there is no other explanation for the child's motor difficulties. So other diagnoses such as cerebral palsy, Duchenne's muscular dystrophy, other medical or genetic conditions that would explain the motor difficulties, or visual impairment or an intellectual disability. So DCD is like a rule out diagnosis. So once you've explored other options for medical conditions and there's no other explanation, then the child may be classified as DCD, as having DCD. So we'll talk about these criteria a little bit later, because you as a parent might need to advocate for your child to be assessed or diagnosed, because it is an under-recognized condition. I also just want to mention that DCD rarely occurs by itself. It's the exception rather than the rule. More often than not, the child may have other neurodevelopmental conditions, in particular difficulties with attention, and even if they're clinically significant difficulties such as attention deficit hyperactivity disorder. So there's about a 50-50 overlap of children with ADHD. And the reverse relationship is also true. So if a child has ADHD and has persistent motor problems, they may have an underlying motor disorder called DCD, rather than there is some assumption that some children may have motor difficulties because of their inattention or impulsivity or hyperactivity. And while that may be the case for some children, even when those symptoms are controlled with medication, they still might have motor difficulties. DCD often also occurs with other learning disabilities. So could be in reading, writing, or math, for instance. And they may have had a history of speech delay or difficulty with speech articulation. It's also common. Up to 88% of children with autism also have motor deficits consistent with DCD. And it's only been in the last several years that a child with autism can have a dual diagnosis with DCD. And so that the disorder is definitely underrecognized in this population. And more relevant for all of you today is that children who are born very preterm, so less than 32 weeks, are 6 to 8 times more likely to have DCD compared to children who are born full term. So preterm babies are at significant risk for DCD. If your child has DCD, you probably know this already, but the majority of children do not outgrow their motor difficulties. What's happened in the past is a parent might go to their physician, express concern about their child's motor difficulties, and the response they get might be, "Oh, don't worry about it. We all can't be athletes," or no big deal, they'll outgrow it. And what we know from longitudinal research is that that's not actually the case. And in fact, the gap widens over time. So playing with their peers, you may notice subtle differences when they're younger, but as your child gets older, the gap between typically developing peers gets wider. That being said, however, what I can say is although the motor deficit may not go away, the impact that it has on daily life can be managed. And as an adult, you have more choice about the activities in which you want to engage. So when you're a young child, you have to do art and you have to do PE and you have to print in the classroom every day. As an adult, you can choose to use a computer. You can choose if you're going to engage in sports or not. You don't have to do the activities in which you find challenging if you don't want to. So the impact that it has on daily life can lessen. Concerning though, because of these motor difficulties, oftentimes secondary psychosocial difficulties develop. So children with DCD might be more at risk for anxiety and depression because they realize that they're not as good as their peers. And if they don't know they have a disorder, they tend to start to blame themselves. And this is one of the reasons why a diagnosis is important. In my experience, it's been very comforting for children to realize that it's not their fault. There's a medical reason why they can't do things the way that their friends do. And we also know that it does have an impact on quality of life. And so we use this information. Why we want to highlight these negative consequences is so that physicians and healthcare professionals, teachers, and the people who work with children with DCD understand the broad impact that this disorder can have on daily life. And this is something I can't emphasize enough, and why my research program has tried to increase awareness of this disorder, the impact it has, and then more importantly, being able to advocate for better supports and services. So I don't mean to be a negative Nelly. I will turn things to be positive in a moment, but just trying to make the point that this is something to be aware of and pay attention to. So you're probably asking, well, what causes DCD? Why? How does it come about? Well, sad to say that little is actually known about the cause of DCD, but what we do know, and myself and others who study DCD have looked at the brains of children with DCD and to look at how they might be different from their peers. And we've noticed a difference in brain development, the structure of the brain, and how the brain functions. And so there are differences in the brain which may explain why children with DCD struggle to learn motor skills. You'll see later on in the presentation that we can actually change the brain with rehabilitation. So all is not lost here. So there is some brain differences. And if we think of children who are born preterm, they're in the NICU at a time when the brain is rapidly developing in that third trimester, particularly the cerebellum, a part of the brain that's responsible for movement and balance, but also for thinking skills and emotional skills as well. So being outside of the womb at that time, the brain is more vulnerable to these outside influences and may affect brain development. There is also some preliminary evidence that suggests genetics may play a role, so it can run in some families. We haven't identified a specific gene yet, but there are some studies that are suggestive of potential genetic contributions, and we've applied for funding to do some genetic studies in the future. And then there's some environmental influences that also may impact DCD. So some literature has shown that if you had a fever during pregnancy, or if you were exposed to secondhand smoke, might have a small association. Events around birth may impact brain development. And then, of course, that time after preterm birth during that period of rapid brain development. And not so much the prematurity per se, how young your child was born, but what happened during the NICU stay. So exposures to medications or painful procedures or infection seem to be more predictive than prematurity itself. So the long story short is that DCD is probably due to a complex interplay of brain development, genetics, and environmental factors. So how do you get a diagnosis of DCD? Well, despite it being so common, it is under-recognized and underdiagnosed. We have made some great headway in this regard in terms of increasing awareness of physicians and therapists about the disorder, but we're not there yet. So you as a parent may need to advocate to have your child assessed, and may also need to provide some education to the professionals with whom you're working. So the diagnosis usually requires an assessment by two professionals, which is also the challenge in obtaining a diagnosis. Usually it's an occupational therapist and a pediatrician who would make the diagnosis, but other professionals can be involved, such as physical therapy and psychology. And I'll explain that in more detail in the next coming slides. So it's important to note it may be an OT or a PT who may first bring to your attention that your child may have DCD or may be at risk for DCD. But we as therapists cannot provide a diagnosis. The diagnosis actually needs to be made by a physician. And in some jurisdictions, psychologists can also make the diagnosis. So I'm just going to go revisit those diagnostic criteria that I mentioned at the beginning. And the first one being that the motor skills are substantially below what you would expect. This is normally assessed by an occupational or physical therapist who would do a standardized motor assessment. And from that assessment, your child's results would be compared to norms of a child of a similar age to determine where your child fits. And if scores are significantly low on this motor assessment, that means they would potentially meet this diagnostic criterion. So this is only one of the 4 criteria. So the low motor test might not be, is not sufficient to make the diagnosis, but it is an important one. And physicians often don't do this assessment or are not aware of how to do this assessment, which is why the therapy assessment is important. The second thing is how does this motor deficit interfere with daily life? And how we assess that, again, normally through PT or OT, would be interviewing you and or your child, depending on their age, or giving you a questionnaire, and most likely both, to get feedback from you on different activities of daily living and how your child performs each of those tasks. And then the other 2 criterion, the onset of symptoms in the developmental period and not better explained by some other condition. This is where your pediatrician would come in, or other pediatric specialist, through a developmental history and a neurological exam, and perhaps other medical tests as required. And psychology may also assess your child's view or cognitive functioning, but this might not be necessary if your child has a history of, normal school and academic achievements. It means that they could still have a learning disability, which is fine. That's not related to IQ. But we want to make sure that to make this diagnosis, that there's a gap between your child's intelligence and their motor skills. So they may be of average to high intelligence, and their motor skills are significantly lower. And so why is diagnosis important? I get this question asked a lot because currently there is no additional funding for children with DCD to receive support. But my argument is that we first of all need to show that this is an important and diagnosis to consider and the impact that it has on daily life. And so without that diagnosis and recognition, we don't have any impetus to create change. And so that's part of the reason. Somebody else often asks, well, what's the point in diagnosis? There's no treatment anyways. And while it's true that there's no pill that you can give a child to reduce the symptoms, or surgery or any other medical treatment, there is therapy. And while it's not a cure, it can certainly improve the child's ability to function and learn motor skills in day-to-day life. And then finally, just with strength in numbers, we can advocate for policy change, not unlike parents of children with autism have done and been able to secure funding to support their children. So this is why I'm really passionate about diagnosing DCD. And the other reason is increased understanding. So what I can tell you is once teachers, for instance, realize that a child has a medical condition, they are much more likely to be supportive and promote a learning environment for your child, as opposed to thinking, gee, this child is really bright, but Johnny only writes 2 sentences in his journal. And, the teacher realizes he has so much more potential, but the first thought might be, oh, well, he's lazy or he's unmotivated. And we want to stop that conversation and realize that Johnny has trouble because he has DCD, and these are the ways you can help. I just want to share with you 2 toolkits that we have developed based on the current evidence in the literature. These are meant for therapists and for pediatricians, but it might be useful for you as well to take a look at these toolkits. It gives the latest evidence about diagnosis and for physicians how to review the diagnostic criteria and to determine if the child has the disorder. But there's also in there, we have a template letter for writing your MLA about increasing support and services for children with DCD, such as increasing funding for occupational therapy assessment and treatment, for example. So there is a piece for you in there as well, and the other information just arms you with the information you may need when you're seeking help. Okay, so what about treatment? Well, the literature shows that the best evidence indicates that physio or occupational therapy are better than no treatment at all. So there's no question that therapy is good, but the type of therapy does matter. And we have the strongest evidence that we have is for an approach called co-op for short. And the long name is Cognitive Orientation to Occupational Performance. And what this is cognitive strategies to overcome the motor difficulties or to learn motor skills. Because children with DCD do not learn the same way as children without DCD. And this task-specific approach, meaning you have to work on the skill that it is you want to learn, not the components that make up the skill. So for example, if your child wants to learn to ride a bicycle, the therapist should be working with the child to learn to ride a bicycle, not working on balance or if your child wants to learn how to print legibly, not working on fine motor skills, for instance. What we know from how the brain works and the brain learns, you need to practice the task that you want to learn. So that's how the therapy should be focused. And I'll just spend a little bit of time about co-op. And without getting too technical here, I just want to tell you that it's based on 7 key principles. The first being that it's client-centered, meaning that the therapist should work on child and parent goals. And so young children can identify goals themselves, like they want to be able to shoot hoops or tie their shoelaces, for instance. But you as a parent might be more concerned about their printing skills or their ability to cut with a knife and fork, for instance. So with some collaborative problem solving or goal setting, we're focused on what it is that you and the child wants to achieve. And we're focusing on the performance of that skill, so not the component skills. We use a problem-solving approach that works on strategies to overcome those difficulties, and what we call identified through a process of guided discovery. So what that means is the therapist is helping the child problem solve to identify strategies that can help them, so that when the child encounters another situation, they have the skills to be able to determine strategies to support them. So it's sort of a hands-off therapy, if you like, and that it's a very active involvement of the child, and also for you as a parent to learn the same strategies and problem-solving framework that the therapist uses, so you can help with this at home. And then ultimately, this is to enable skill acquisition. So just to give you a sense of what this may look like, typically this is offered over 10 sessions of 1 hour each. So it's not like you're committed to therapy for life. It's a short time frame. And the protocol suggests that you work on 3 goals that you and the child want to achieve. So you spend a little bit of time on each goal in every session. And what the therapist does is determine, has the child perform these 3 goals, and determines where is the breakdown, or what's happening, why is the child not able to do the task. And then the therapist helps the child discover strategies, which I'll talk about in a moment, and then hopefully evaluate the treatment. So we ask both the child and the parent to rate performance and satisfaction in terms of meeting those goals. So the global problem-solving framework is called Goal, Plan, Do, Check. And just briefly, this is about the child having a goal. So let's pick skipping, for instance, because that's what I'm going to show you a video on later, is the child wants to learn how to skip. And so the therapist observes the child skipping, realizes that they're not actually jumping over the rope. They're just sort of stepping over the rope. So the plan may be to be able to jump on 2 feet, for instance. They do that, and then they evaluate how it works. So once they've worked on that skill, are they able to jump on 2 feet? Yes, you keep that in the plan. Then you go back. Okay, now why is it that they can't jump the rope? So now they're able to jump, but they're not able to get the timing right with jumping over the rope, for instance. And so you make a new plan, check the plan, and so on. So the goal could be the overall goal, being able to skip, but then also those mini goals that are needed in order to achieve that motor goal. Now, in terms of strategies, I just wanted to give you a high-level view of this, just so that you're aware of what to ask for when you are looking for a therapist. So I would ask if they are familiar with co-op. And then the types of strategies that they may use are looking at the child's body position. Are they in the ideal position to skip, for instance, or are they leaning their body too far forward? Are they paying attention to the right part of the task? So, for instance, if you're working on ball skills, are they following the ball with their eyes, or are they paying attention to something else in the environment? Does the task need to be modified in some way for them to be able to be successful? Do they have the knowledge that they need in order to perform the task? Or are there strategies that can help with verbal reminders of how to do the task? Or for sequences of movements, having a rote script that they say in their head. So it's very much a cognitive, verbal, problem-solving approach. So just as a scientist, I have to give you some data. So I'll just explain these results here. So these are after we did a randomized controlled trial of children who received co-op intervention compared to those like pre and post. So on the side here, we have a scale from 0 to 10 and motor performance and motor satisfaction. So how well did the child rate their ability to perform their goals, and how satisfied were they with how they performed those goals? In blue here are how the children scored before intervention. In this teal color, it's how they scored after intervention. And you'll see both performance and satisfaction improved significantly. So the children met their goals and they were satisfied. So this is both statistically significant, but also clinically meaningful. So, and this, the quality of performance was actually a therapist rating the child's abilities before and after intervention. So they were not involved in the study, and they were looking at videotapes. They didn't know what was a pre-video versus a post-video. They were just scoring the child's movement. And you can see their scores are very similar to how the children perceive themselves. But now let me show you with a video of a child before intervention and a child after. So Fabi's going to video for us. So this is a child who we'll call Heather. I have permission to share this video. So this is how she looks before intervention. So you can see she dropped the rope before even starting. Sorry, there was a bit of delay there, but I hope that you can see that she was essentially throwing the rope over, then kind of stepping over the rope and starting again. She couldn't really skip per se. So she went, participated in one of our studies and did co-op intervention. And wow. So I think you can probably hear it better than seeing it with the delay in the video. But not only was she now able to skip, she was alternating feet. So left foot, right foot, increasing her speed and how she could skip. And that's after just 10 sessions. So that was one of her 3 goals. And so that's the data coming to life for you. So that's how effective this approach can be. The other exciting thing is, so that's the therapy side of me, the scientist part of me, also wanted to look at, can we change the brain with this intervention? And in fact, we can. And so without going into a lot of details, what I can tell you is that the white matter pathways in the brain, so how information is transmitted in sensory regions, motor regions, the corpus callosum, which communicates across hemispheres. And so those white matter pathways showed greater maturation. We had increased volume of the cerebellum, so that brain area that we think is implicated in the disorder. And so we increased volume in that area of the brain. And we also showed that the functional connectivity within the brain also improved in what we call the sensory motor network. And so this is very exciting to me to show these brain changes, because I think this provides us with excellent evidence to take to government and policymakers that not only can we improve the child's motor skills, but we're actually changing brain structure and brain function. And I'm hoping this argument will be that it's unethical not to treat children with DCD with these types of findings. So that's what I'm hoping will come from this work. Just in the last couple of minutes here, I just want to share some resources with you. So this is, I'm part of the Canadian Pediatric Society, and we wrote a paper for physicians, but we also partnered with the Caring for Kids website to write up some information about DCD. So that's available for you. It's just a one-page information sheet about DCD. We also have on the CanChild website an online parent workshop for you to learn more about DCD, and there's several different sections that you can work through independently, and you can log on as many times as you need to. You don't have to finish it in one sitting, but that provides a wealth of information over video. And there are also numerous handouts that would be useful for your child's teacher, their coach, other medical professionals, about a description about what DCD is. And for example, they have handouts for teachers for grades 1 and 2, grades 3 and 4, the PE teacher. And they outline these strategies here, which we call match. So how to modify tasks, alter expectations, teach strategies, change the environment, and help by understanding. And that help by understanding, I can't overemphasize enough that even if we are not successful in getting additional funding and support for children at school, this help by understanding goes a very long way to protect your child's self-esteem and have a positive experience at school. And that's most important, I think. And lastly, if you are interested in being contacted for research into DCD, I invite you to email my research coordinator, Sarah Leckie. And if you are eligible for any current or upcoming studies, we would send you information about it. You are under no obligation to participate. Just being on the email list means that you get information and then you can choose to participate or not. And we also prepare a newsletter once or twice a year from studies that have come out of my lab and the latest evidence. So I invite you to do that if you're interested. And lastly, I just want to acknowledge the children and families with whom I have the privilege to work, my research team, my trainees, and my sources of funding that allow me to do the work that I do. So with that, I'm happy to open up the discussion.
Wow, Dr. Zwicker, thank you so much for all this information. We have few questions in the chat. This is so enlightening, and it shows how much work we need to do to educate community, pediatricians across Canada and worldwide. We actually have some questions from outside Canada. My first question to you is, because you said you needed 2 people to give a diagnosis to this child, and we work with neonatal follow-up clinics in Canada, and some clinics go until age of 3, other clinics go to age of 6. Is this diagnosis a possibility to come also from neonatal follow-up clinics?
Absolutely. And in fact, this is something that I'm working with the Canadian Neonatal Follow-Up Network about. We know across Canada, not all follow-up programs are screening for DCD, and others have an established protocol that they've had for a long time. So we're hoping to create consistency across neonatal follow-up. But if the follow-up clinic only follows children to, say, age 3, you can't actually make a diagnosis really at that age. However, what I've encouraged people to do is to use the term at risk for DCD, so that that child can be further assessed outside of neonatal follow-up. At very young ages, you actually need 2 assessments, at least 3 months apart. And the purpose of that is to determine if that motor deficit is persistent or if given more time, the child catches up. And so we don't want to provide a diagnosis that is not appropriate. So under the age of 5, we generally do 2 assessments at that time.
Okay, so let's go to the chat now. Actually, we had a few comments of people saying that you're actually talking to them about them, which is great, so people can relate to what you're saying. We have a question here from Andrea. Does age of intervention matter?
That's a great question. So So the results of the study that I shared with you, those children were 8 to 12 years of 8 to 12 years of age. And so they made those changes even though they were older. Obviously, I think the argument is the sooner we start, the better, so that we can change that potential negative trajectory. But we don't have evidence there yet, because it's only recently that we've started to consider identifying children at a younger age, and then intervention has to follow. So we do have some, we've reviewed the literature and have come up with suggestions for early intervention, but now we need to test those specifically.
So for the brain, for you to see the transformation in the brain that so all the kids in your study went through MRIs to see the change in the brain?
Yes. Yes.
Oh, that is amazing. Okay, we have more questions here. Are these skills retained if they stop doing them for a period of time? For example, if they skip in the summer and fall and then don't skip all winter, will they be able to skip again in spring? Thank you, Karen, for asking that question.
Good question. So, so the skills do last. So, and so do the brain changes, actually. So what we did was we also looked at children 3 months after intervention stopped. And not only did they maintain the changes to the brain, but they also showed additional changes, because now they were more confident. This is what we're assuming. They're more confident to try things and are engaging in more activities and using the strategies that they were taught. Now, if the child is, if a season goes by, I would say that they might need a tune-up, so to speak, just to sort of recall those skills. But it shouldn't be like you're starting from scratch and they have no idea. I think they might just need a bit of trial and maybe some reminder strategies, but they should be able to resume the skill if it's deteriorated a little bit.
That is great. So I loved the principles of the therapy, the co-op therapy based on goal, plan, do, check. This is so great. And my son has cerebral palsy, but I also wish we always had these principles in all his therapies, because it's so nice. Like, it's a family goal. What do we want to achieve? I think it's so important for, any diagnosis, but obviously for this one is a very specific one. My question is, how many people in Canada are trained on this kind of therapy? Is it wide available across the provinces in the country?
So I just want to comment first in terms of cerebral palsy. We do have evidence that this approach works with children with cerebral palsy, for sure. We also are, there was some preliminary evidence that it works with children with autism, but we're doing a similar brain imaging study as well. So, and it works with adults with neurological conditions, like with stroke or brain injury. So while it was developed for DCD, it has had good uptake and good results in other populations. Now, in terms of training, my hope is that every undergraduate or every master's program that trains PTs and OTs will have at least introduced this type of therapy. And then there is training that people do after graduation. This training is available across the country. There is a whole academy called the ICANN Co-op Academy, and they have trained therapists around the world. And so as more of these courses are offered, more and more therapists will be trained. And even without the formal training, if people are familiar with at least the approach and the theories, they could provide at least, some of the treatment principles. So ideally you want somebody who's fully trained, but if they know what it is and are using that approach, then that's the next best thing. What you want to try and avoid, especially for children with DCD, because we have evidence that it's not effective, is working on those component skills or the sort of sensory integration or sensory approaches. the child with DCD might also have sensory issues, and that would be treatment for the sensory issues. But to work on the motor skills, those other approaches are not effective.
Okay. So let's continue our questions here. Are children with DCD also more likely to have a challenge with toileting, including nighttime training and having bowel movements?
So that's a good question. Now, I have had anecdotally, parents have, I've heard that from parents. There's not a lot of research to show a relationship there, but what I can tell you for sure is that children with DCD may have more accidents because they have trouble managing their clothes independently or fast enough at school, for instance. So they are more prone to toileting accidents. Whether or not that actually interferes with their nighttime training, for instance, I'm not sure, but I have heard that from parents.
Okay. The more you talk, the more I think how important it is to have this diagnosis, especially for school, to know. When you're talking about, the teacher saying the child is lazy, you always make me cry because it's such I grew up with a brother who had dyslexia, who wasn't diagnosed. He wasn't diagnosed until he was an adult. And I went through all that with my brother with no diagnosis of dyslexia because they call him lazy because he couldn't really learn. So we will talk about this. It's like, oh my God, yes, if you have early diagnosis, how much we can bring out of those children, the potential and the compassion with the teachers and adaptations in the classroom. So important.
I'll just add to that in that we did brain imaging work to show that children with DCD actually recruit almost twice the number of brain regions while doing a fine motor task compared to typically developing children. So imagine that a child who's working twice as hard as the child next to him, but he gets told that he's lazy or unmotivated. Like that's like a double whammy to me. And I've interviewed children and talked about that and how frustrating that is and how they don't use the term demoralizing, but that's how they feel.
Absolutely. So I have one more question here from Celia. Thank you so much for joining us from US. Do you find in your research that there is a misdiagnosis or co-diagnosis of SPD, sensory processing disorder, for children with DCD? She's a nurse educator in Arizona.
Great question. So, and thanks for providing the context of the US because in particular, most therapists who are trained in the US are trained in a sensory integrative framework. And so they're more likely to diagnose sensory processing disorder or dyspraxia, for instance, than DCD. We're hoping that's changing. So there may be a case where a child may have both DCD and sensory difficulties. And I'm engaging in research right now, actually, my hypothesis is if a child has sensory difficulties, it's not because of DCD, it's because of some other co-occurring condition like autism or ADHD or where we know there's sensory differences in those populations rather than it being DCD in and of itself. And so we're undergoing that study now to evaluate if that hypothesis is correct.
Okay. So one more question here. Do you have a device for things can we parents do try to decrease the risk of development of anxiety and depression in our kids who feel isolated because they can't participate in sports, gym, and have problems connecting with children their age?
Very good question. So yes, there's lots we can do when we have knowledge, and knowledge is power. And so that goes for the child as well. So if they are aware that, and it can be discussed in a positive way, that their brain works differently than other people's brains, which means sometimes they have to do things differently, or it takes a little bit more effort. And once they are aware of that, they can start to advocate for their own needs as they get through higher and higher grades. But to really what we really want to do is protect their self-esteem. And so not, there will be things that they're not able to do as well, but to put it in context, also the therapy can help if we're having those specific goals that we want to address. And also just to be, as a parent, to be really mindful about your child's words or how they're describing themselves. Like I had one little boy who called himself a loser because he couldn't do anything. And he just he was 7 years old and he was kind of resigned to the fact that he was a loser. But once he realized that, he had this condition and there were things that we could do about it and that he might have to do things differently, it kind of changed his perspective. And the more we can educate the people around the child who are their support network, that could include parents, grandparents, teachers, coaches, that they need to do things differently, or we can support them in this way. The child has more success experiences rather than those negative, can't do it type of experiences. So without any adaptations or therapy, if we just confront them with daily life and that's challenging, they're going to feel that anxiety and depression. And so that's why we want to identify them sooner, intervene sooner. And there's a lot we can do in terms of the environment and the people around them.
Absolutely. And we're going to leave with Karen's comment about her son. On a personal note, my son told his class that he has DCD, and his classmates asked, "Oh, is that why you fall a lot?" And he said yes, and it has been such a positive experience for him. Well, again, reinforce the importance of the early diagnosis and empower the child, right, to become their own advocates.
Yeah, and it is, and I've seen this. I know that some people maybe don't want to have the label, or they don't want to tell their child that they have the diagnosis. But time and time again, my experience tells me exactly how you described, Karen, that once the child knows and then they discuss it with their friends, then their friends can be supportive as well. And one example I'll give is about a child who was in our research study who did the co-op approach. He happened to see a child at school who was struggling with tying his shoes, and he says, "Oh, hey, I've got an idea." And so he gave his strategy to another child and passed it on to somebody else. And it was just a beautiful thing to hear about from his parent, that now he's empowering others. So.
Wow, it is so amazing. It's such an important work, Dr. Zwicker. Thank you so much for sharing your knowledge with us today, your research. And honestly, I feel like CPBF has a lot of work to do with you, so we can make this information available, disseminate the knowledge, and really educate professionals in the community so they can support our families. So thank you so much for being here with us today.
My pleasure. And thank you so much for joining, and thank you for listening.
Thank you. And to all of you watching us live here today, thank you so much for joining us. And the video of today's session and all the other videos from our PREMIChat series is on our website, which is right here, the canadianpremis.org. And I want to thank our sponsor, AstraZeneca, for their ongoing support of our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensure they're ready to care for their babies. Please visit our website and consider making a donation. Together, we can create a brighter future for all our families. And we'll see you again next Friday, 1 p.m. Eastern Time. Stay well.